Hi, this is Brian Kim. I want to share with you this case of a patient who has referred to me. This patient had a dislocated IOL, a dangling dislocated IOL, due to a direct trauma to the eye. The patient ended up with a complete dislocation of the lens and bag complex. And you're going to notice that the lens is dislocated infranasally. This is the left eye. And so this is very important because as I look at this lens, at the slit lamp exam, it's very obvious that the lens is sitting posteriorly. And so you have to think to yourself, okay, as a patient sitting upright, it's sitting very posterior. Therefore, when the patient's lying down, it's going to fall even further back. And so you have to ask yourself, will I be able to actually get to this lens? And if I have trouble getting to this lens, what strategies can I employ in order to get that lens up? And you're going to see a really cool technique that I did on this case. As you can see, this is at the slit lamp. This is the left eye. And I'm having the patient look side to side and up and down. But you can see the lens is dislocated infranasally. This is the left eye. But also the lens is sitting really far back. So it's not just at iris plane. It's sitting much more posterior in the anterior vitreous space. Interestingly, there's not much vitreous that I see in the anterior segment at all. This is looks like a three-piece lens. And you can see this patient's moving their eye. You can see the RK scar. So this patient's had RK, high myope, and she's also had a previous vitrectomy. So that complicates things as well. So previous vitrectomy, and obviously then there's going to be less vitreous support, and that's why this lens is falling back. And so it's very important when the patient's sitting upright and you see it sitting that far back, it also means that when the patient lies down, it's probably not going to be easy to access. And so you can see here, I'm sitting supratemporal. The lens has dislocated infranasal, and it's sitting vertical. Okay, it's hanging by a few threads of zonules. You're going to see a cool technique that I'm going to employ by strategically placing a trocar to be able to help me lift that lens up with the levitation technique using the vitrector. So I'll go ahead and use a pre-inked cannula. I mark the limbus, and then I'm finding 180 degrees apart, making sure the conjunctiva is dry with a Wexel sponge, and then marking 180 degrees apart on the other side. And then these are the fixed caliper markers, 2.5 on one side, 2.0 on the other side by epsilon. I'm marking posterior to that mark 2.5 millimeters in a radial fashion, and then 2 millimeters adjacent using the indentation, drying the surface, and then using that cannula that's been pre-inked, and then quickly marking those spots with the ink. Do the same thing on the other side using that fixed caliper. Again, 2.5 millimeters posterior to that mark in radial fashion, and then 2 millimeters adjacent, indenting the sclera, and then following it with the ink. Again, the pre-inked cannula to mark those spots. I like the cannula. It gives you much more discrete marks versus using the marker directly. It tends to bleed and smear everywhere. It's a less discrete mark. And by having a more discrete mark, you'll be able to see the needle more clearly when you're trying to tunnel through the sclera. So I've made my marks, and this is the trocar. I'm going to indent 4 millimeters posterior, but look what I'm doing. I'm making the mark for the trocar right over the area of dislocation. So I know where those zonules are. They're just anterior to that mark. I'm going to move the conj, and then with tangential forces, I'm going to tunnel through the sclera, tunnel 3 millimeters or so, tunnel, and then I'm going to turn vertical, perpendicular to the surface of the sclera, and then I push down. Use the cotton tip to hold the trocar in, take the needle out, and now I'm right underneath the lens. And so this is really cool. I go ahead and make my other incisions here, first on the right side and then the left side, which are going to help me to grab the lens and pop it up into the anterior chamber so I can cut it out. This is the angled paracentesis blade from Diamatrix, and by using this angled blade, you have easier access, especially in these areas where the nose is in the way. It's much easier to be able to make a nice flat approach for your incisions. And also, of course, this patient's had RK, so you have to kind of navigate around those incisions as well. So again, my 2 incisions to be able to remove the dislocated lens, the contra-incisional incision to externalize a leading haptic, and this is the last incision for my AC maintainer. I'm going to go ahead and inject some dispersive viscoelastic to coat the corneal endothelium the best that I can. Again, this patient's had vitrectomy before, so it's going to be hard to get a nice coating of the cornea, but I'm going to try anyways. Also want to firm up the eye a little bit as I make my incision. So I use that same cannula to hold the eye. You can see the lens dangling and kind of swinging back and forth. And again, this patient's had RK, so I have to be really mindful. I really don't have a lot of options in the positioning of my main incision. I have to put it right there. And those RK marks are pretty tight. And so I'm trying to stay as far peripheral as possible. And then I enter. I'm trying not to go too anterior. I don't want to intersect those RK incisions. So now that I've made all of my incisions, I'm going to go ahead through the trocar with the vitrector. Now, of course, the vitrector is tricky because it's straight and the nose is in the way. And so I'm going to go ahead and try to get to the lens. I know that trocar is in the correct position to be able to lift that lens up. There's no other way I could get to that lens. Trying to grab it from the main incision or some other incision would be completely futile. And so you want to lift it up. This is what I'm doing. I have micro graspers on the other side, on the left side. First, I tried through the para, and I was like, let me try to go through the main incision since the haptic is presenting itself closer towards the main incision. So I'm lifting with the vitrector, lifting the lens up. I'm tilting the vitrector through the trocar up. You can see the eye is turned down towards me, partly because, remember, that vitrector is straight and that nose is in the way. I've grabbed the haptic. I want to make sure I get a good firm grasp. So while I'm supporting the lens with the vitrector, I take another grasp, which is a good bite. And then I take the vitrector out. And then I'm going to grab with another IOL holder here. And you want to use the IOL holder because it has a serrated teeth. You don't want to use something that has smooth teeth in this situation. You don't want to lose the lens. So in this case, I have 2 IOL holders. One in the right hand, one in the left hand, and now I decide to grab the optic, and then I switch hands, go through the para on the left side, and then I'm going to go ahead and grab the optic a little bit better, kind of like a handshake technique here. Now that I have good grasp with the left hand, while I'm holding the lens, I go ahead and push some more dispersive viscoelastic to coat the corneal endothelium. And then now I'm going to cut the lens. You can see I have the teeth closed first, wiggle it in. And then as I cut, I have the teeth a little bit sideways. I'm cutting the optic only. You can see this is a 3-piece lens. Very carefully, I'm cutting the lens in half. I'm trying to pull the scissor out. It's getting caught on some of that capsule material. And while I'm holding the left half, still with the micro forceps, I'm going to then use another set of micro forceps to grab that trailing haptic. Very carefully, I'm handshaking it to the tip, pulling the tip of the haptic out, and then grasping the edge of that optic, and then pulling it out. But then with the forceps in my left hand, I'm grabbing the other haptic just to make sure it doesn't want to fall as I do this. So again, pulling the lens out with my right hand, and then holding the leading haptic with my left hand just to secure it in place. And while I'm holding the leading haptic, now as I'm turning the eye away from me, I'm trying to grab the edge of the optic. Unfortunately, it's getting caught on the incision a little bit, so I push it with the teeth closed so I can access the optic edge a little bit easier, and then I grab it. Once I grab it, I shield the corneal endothelium with the microforceps, and the lens comes out. So again, fairly systematic way I attacked the removal of the dislocated lens, strategic placement of the trocar just underneath the hinge where the zonules are holding the lens, lifting it using microforceps to grab it, cutting it in strategic manner, like I said. You saw I pushed some more dispersive viscoelastic, which helped to push some of that Summering's ring and capsular material out of the main wound, but you really need better infusion. So this is a 22 gauge Agawa large bore AC maintainer. It's a great AC maintainer. And as I put the AC maintainer in, I turn infusion on. You can see that capsular bag material starts to come out. I'm using a cannula to tease that Summering ring matter up, and then it comes out. So again, this patient, again, like I said, has had a vitrectomy before. This patient's had a retinal detachment before. And so at this point, vitreous shouldn't be a major issue, but of course you always have to check for it. And I'm still going to do a vitrectomy. This 22 gauge large bore AC maintainer is great because it goes through a smaller incision. With the other 20 gauge AC maintainer, yet it created a lot of infusion pressure, which was good, but those incisions needed to be widened and they tended to leak in my experience. This is a much better AC maintainer. Again, the 22 gauge Agawa AC maintainer through Epsilon. I'm starting to do some vitrectomy through the trocar, but as you can tell, this is a very awkward position to do vitrectomy. I did some vitrectomy through the trocar, and then now I'm going through the temporal paracentesis incision, doing some more vitrectomy. But the truth is, there's still some vitreous there. You see, I use a Weck cell to check, and there's just a little bit, not a whole lot, just a little bit of vitreous. It's always a fine line when you're dealing with these cases. I firmly believe when you have a dislocated lens, the vitreous in the anterior segment is very, very liquid, and so it's a very low risk for causing any problems. But nonetheless, you want to manage it and deal with it. But you can see here, this is a cool technique. This is the first time I've ever done this. I'm going to go ahead and put the needle back, pull the trocar out, and because it did a nice tunneled incision, that incision is going to self-seal. Turn on infusion. I've turned on infusion. I go ahead and indent in a more easy ergonomic location to do the vitrectomy. Again, I placed the trocar infranasal so I can lift the lens, but again, the nose is in the way. It's not really very easy and practical. So what's cool is go ahead and put the needle back in, take the trocar out, and now I've repositioned it in a place that's more natural, more ergonomically easy to do. So I go ahead and tunneled in my typical self-sealing technique. And then I'm going ahead and do the vitrectomy. You can see this is so much easier to do the vitrectomy without the eye turning and so forth. We go ahead and inject some intracameral triamcinolone just to, again, confirm that I don't have any vitreous in the anterior chamber anymore. Again, I don't have any vitreous in the anterior chamber, which is excellent. And so now we're going to focus on our needles. This is the right side needle. I bend the needle about 9 millimeters from the tip, and I angle it about 70 degrees, but I make sure that the bevel faces towards me as the syringe is held up and down, because I'm going to hold the syringe like a pencil in my hand. And so I want to make sure that the bevel is facing towards me with the right hand. The left hand, I'm going to bend the needle about 70 degrees, but again, the bevel is going to be facing away from me. And so those are the needles to cannulate the haptics. And this is a 25 gauge needle. I want to bend the needle about, 80 degrees, and the bevel is going to face towards the right. And that needle, the 25 gauge, is to externalize the leading haptic. This is some cohesive viscoelastic filling the chamber of the cartridge. This is the sensor lens. I was just barely holding it. It just kind of fell, but that's fine. I'm going to turn it over, making sure it's seated deep in the cartridge, making sure that the leading haptic comes out straight, making sure the optic is concave, making sure the trailing haptic comes out of the cartridge, sticking out just like that. Bring the wings together, placing it within the injector now, pushing it all the way through. But you want to make sure that the trailing haptic is up and out over the green part of the barrel, which you can see there. I'm pushing the plunger forward to advance the lens. And again, this is a twisty type advancer. And as I twist it forward, you'll see the lens coming forward. You want to make sure that both haptics are still on the optic as you do this. Okay, I'm ready to go now. So I'll go ahead and place the 25 gauge needle that's bent facing to the right. Again, that's the blue hub needle here. Going through the contralateral incision, placing the injector bevel down, turning the bevel to the left, having my assistant advance the lens. And as she does this, the leading haptic comes out. I make sure I align the haptic to the needle, docking the haptic on the bevel of the needle. And as I align it and she advances the lens, the haptic goes into the needle very nicely. And as I withdraw the needle out, the haptic comes out as well. Again, this is a no grabbing technique, because if you grab those haptics at the tip and you crimp it, then they don't cannulate into the 30 gauge thin wall needles. I take over, allow the optic to open up, and then make sure the trailing haptic is pointed to the right. You can see this lens is just not opening that fast. I think it must have been sitting in the cartridge for a little bit, but that's fine. Just give it some time to open up completely before you proceed. Inject some dispersive viscoelastic to push the optic down and also to coat the corneal endothelium as well. And at this point, the AC maintainer is on. The only problem here is you can see there's some ballooning of the conj. That's the only downside, but I feel good about the positions of my ink marks. I feel like that's proper. I have the needle. I'm stabbing at the first mark, tunneling through the sclera, making sure I'm flat, tunneling to the other mark 2 millimeters next to it, and then diving down towards the nerve and then rotating. You don't want to rotate superficially. You might scrape the ciliary body. You want to point towards the nerve and then rotate and lift up. And very carefully, this is very, very important. As you grab the haptic, you don't want to have a heavy hand. And you want to slide it over as you put it through the incision. Infusion is on when I place the needle through the sclera. You want to dock the haptic on the bevel of the needle, as I'm doing here. And it's all about angling. And so you want to be very delicate touch as you flatten out the haptic and then gently feed it through the needle. Very important that you have a delicate hand when you do that. And remember, if it doesn't go in, it's not because the haptic is too big, it's because your angle is off. That's been my experience. It's not really that the haptic is too big or the needle is too small. It's because your angle is off. So that takes some time and practice, but it also takes patience and a light touch as you're trying to maneuver that in the eye. I'm disengaging the syringe from the needle here using a hemostat and then letting the needle drop. And then I'm going to use microforceps to internalize the leading haptic. You can see the infusion is on right now. And you want to turn infusion on and off depending upon the situation. And you can quickly do that with the machine. I'm going to go ahead and deposit the leading haptic into the angle. And now I'm grabbing the incision with microforceps very gently, turning on infusion. You have to have infusion on with this maneuver. I have the needle, again, fairly flat to the sclera, puncturing at that first mark, tunneling fairly flat, tunneling through the sclera, 2 millimeters, and then diving towards the nerve, and then rotating up. You need to have a nice scleral tunnel. You need to have that shelf for excellent lens support. If you don't have an adequate shelf, your haptic won't be flat. Therefore, your optic will sag, and you will have a poor refractive outcome and a tilted lens. So that execution is very important. Of course, every step of the execution is very important with this surgery. Using microforceps to grab the leading haptic, docking the haptic on the bevel of the needle. Once you dock it, you can actually re-grab in some cases. You can see here, yeah, just go ahead and re-grab it, because once it's docked, it kind of catches the haptic so it doesn't fall as much. And I found that particularly true for this Sensor lens as opposed to some other lenses out there. So again, dock it, and then you can advance it. Once you advance it a little bit, these needles grip the haptic of the Sensor lens so well that you really don't have to feed it that far. And now I'm going to go ahead and pull each needle out. I start to pull the left side needle out. I have micrograspers ready to grab the haptic as the needle is pulled out. And you want to make sure that the haptic doesn't get stuck within the needle. And I'm just supporting it with the micrograspers, making sure not too much of the haptic comes out. Cauterize the tip. You get a tiny little bulb. Switch hands and do the same thing on the other side. Micrograspers on the left hand now, using your right hand to pull the needle out away from you, making sure you grab the haptic as the needle is withdrawn, and making sure that not too much of the haptic comes out as you're pulling the needle out. You just want to make sure it doesn't cause too much traction on the other side. And then you're going to cauterize the tip, get a small bulb again. But this is very important, and I've said this many times. Look how flat the haptics are on this case. When you have a flat haptic, that means you have a good scleral shelf support. The flagpole sign means the haptics pointed towards the sky, which means you're going to have terrible lens position. The optic is going to sag, and more importantly, you'll have a terrible refractive result if you do it that way. So this is a perfectly centered lens in the posterior segment, just under iris plane. I've pushed the haptics bulbs into the sclera, reapproximated the conjunctiva. Now I'm going to go ahead and place a 10-0 nylon suture through the main incision, which I always do on these cases. And then we'll go ahead and tie it off and then bury the knot. And this is the surgical PI. I'm going to switch it to the surgical PI setting. There's a fixed cut rate, fairly high IOP, but you can see the aspiration rate is low and the vacuum is high. And that's because you want to be able to grab it with vacuum, but don't aspirate too much because you don't want to eat the whole iris. And then you have a fixed cut rate. Again, fairly low cut rate when you do it this way. So you get a nice peripheral PI there. And then going through the trocar, do some more vitrectomy, making sure I'm getting all of the vitreous out. There isn't any vitreous left by this point, but just going ahead and trying to be thorough. And then going through the temporal paracentesis incision, and I'm going with cortex mode, removing the viscoelastic from the anterior chamber. Remember, I put viscoelastic, dispersive viscoelastic, to coat the corneal endothelium after I put the lens in. And I always do this to create a little bit of a buffer and to push the optic back away from the cornea. And therefore, I have to remove that viscoelastic that's now in the anterior segment. And I like to use the vitrector in cortex mode because all it is just, INA. The infusion is through the Ogawa AC maintainer, 22 gauge AC maintainer, and the aspiration is through the vitrector. Push them BSS in as I withdraw the vitrector. Go ahead and seal my incisions now. Again, you can see a perfectly well-centered lens. Again, this patient's had RK, so of course we did the RK calculation as well for this patient. Go ahead and grab the trocar. You can see first I'm checking my initial trocar site, and this is with infusion on. You can see it's nice and flat. There's no bleb of the conj over there. Pulling the trocar out. As I'm pulling it out, I'm using the cotton tip to tamponade the sclerotomy. And once I do this, I'm just checking the eye pressure, turn on infusion, and you can see there's no ballooning of the conjunctiva. So you can see, again, 2 trocar incisions, both self-sealing, making sure I'm tangential through the sclera as I tunnel and then dive down towards the nerve. Go ahead and place another suture through the main incision. I noticed there's a little bit of leaking of that incision. I didn't show that because I kept hydrating the wound and it kept leaking. I'm gonna go ahead and place another suture through there. I don't know if it's related to the RK incision causing some instability there, but I went ahead and placed another suture. Now I have a nice closed eye. The wounds are all sealed. So again, you had a dislocated lens, infranasal. This is the left eye. I placed the trocar strategically. I placed the trocar right in the area of the hinge. And so that's a very important strategy in order to be able to levitate that optic up. So I placed the trocar over the area of the hinge where the zonules are actually still holding the lens because, it dropped back vertically. So I placed that trocar, was able to use a vitrector, lift the optic up, grab it with microforceps, and using a handshake technique, I was able to get better support, grabbing it, popping the lens up, cutting it out, cutting one side at a time, making sure I'm holding the lens pieces and securing them so they don't fall back, making sure I burp that bag material using the infusion through the AC maintainer to burp it out. But again, as you saw, there was still a little bit of vitreous, even though this patient's had a vitrectomy in the past. So I put some triamcinolone in, made sure there's no vitreous in the AC. Go ahead and did some vitrectomy. But remember, what did I do? I took that trocar out because it's very poor ergonomic location but it's because it's a self-sealing incision. It went quickly. I was able to pull it out, placing the trocar needle back in, pulling the actual trocar out, and then repositioning into a place where I can access it better for the vitrectomy. And then I performed my modified Yamane technique, externalizing the leading haptic using a 25 gauge docking technique through a contralateral limbal incision. Thereby, I'm able to move the entire lens away from me because the leading haptic is outside of the eye. I'm able to access the trailing haptic much more effectively. And again, 30 gauge thin walled needles. We're using the Sensar lens, very delicate holding of the haptic so I can cannulate the needle on the right side and then the left side, pulling the needles out. But then you saw how flat the haptics were on the sclera, and that's because of my previous marks. I made sure I had a nice tunneling of the sclera with the needles, making sure it provides a nice scleral shelf. And then when I pulled those needles out, it was a nice and flat on the sclera, good optic location and support. And so this will translate to better refractive outcomes because of the way I execute the surgery. And again, the biggest take home with this case was the fact that I strategically placed the trocar in the area of the zonular hinge that was still holding the lens. By placing the trocar over the zonular hinge, I was able to lift the lens up using the vitrector and then securing it and then cutting it out. So I hope this was helpful to you, and I thank you for your attention.